So I just heard the tutorial in the other lecture hall is now over, which for me is literally next door in my apartment. So people are trickling in. So maybe in 1 or 2 minutes, we'll be able to start.
Yep. That sounds good. I see that quite a few people are joining right now, so it makes perfect sense to wait a little bit longer.
Yeah, we just ended our other tutorial, so we're all hopping over to this one.
Okay, I think I'll keep admitting people as they arrive, but I think we're good now. We have a very good group actually for early in the morning or late in the evening, depending on where you are. Just to introduce this session, I don't think I have to convince anyone that this is a really timely issue. I'm tracing epidemics and thinking about network-based models for epidemics. So I'm really excited that we have a good group for this session. And we're lucky to have Professor Mikhail Prokopenko from the University of Sydney to present this tutorial. So I'll keep muting everyone. And Mikhail, I think you're already unmuted, so you can take it away.
Yeah, thank you, Laurent. So yes, it is quite topical these days. And I hope that the case studies that we will look at in the next 1 hour and a half will be still relevant. I will not talk about our COVID-19 modeling. I will mostly look at influenza modeling and some foodborne diseases. But the model that I will be concentrating, focusing on most of the time, the agent-based model of influenza modeling shares quite a lot of features with our COVID-19 modeling. So I think it will be quite interesting. So the tutorial will take 1 hour and a half. It will cover a number of case studies, as I mentioned. I'm not planning any real break, but I will give people an option maybe to ask questions at particular times. I think Laurent will help me with monitoring the chat channel, because I can't really see chat as I speak, but at certain times there will be opportunity to look at questions. So don't be shy, please ask questions in the chat channel. So without any further ado, let me move on. And I usually start presentations around, on these topics, in particular computational epidemiology, with this slide, which brings an image from 1918. And if you look at the number of cases, half a billion, 500 million infected, and the population on the planet at the time was around 2 billion. So the attack rate, so to say, is 25. And the death rate was about 3 to 5% of the world's population, which is fairly high. So obviously major pandemics do happen, and we are in the middle of another one, which is yet nowhere near in terms of the attack rate and impact on the world population in terms of numbers. But because the connectivity of the world is so much higher these days, we see impacts on the whole world already quite dramatic, and it doesn't stay in healthcare. It obviously goes into every other aspect of our lives, economic and social as well. So I will not talk about this kind of modeling, global economic impacts or supply chains and all of that. I will focus on epidemiology. I should probably say that I'm not an epidemiologist. I'm a computational scientist. But in the last 4 or 5 years, we've been looking at computational epidemiology quite strongly. So I hope that some of the lessons that I'm hoping to cover today will be of interest to modelers which focus on epidemiology as well. So if you look at, let me see if something is going on with this window. If you look at the epidemic curves, and what you see right now is actually mortality rate, not incidence or prevalence, you will see very recognizable these days a peak of the epidemic or pandemic at the time, with a number of major world cities like New York, London, Paris, Berlin, fairly agreeing in terms of the timing of this peak and even the relative size. And you see that it had a classical peak at a particular time, which was followed by the second peak, the secondary wave. And it doesn't tell the whole story, this plot. As we know, the secondary wave at the time was even higher in places than the first peak. Again, this is just a historical point, but the shape of this curve was quite cryptic at the time, because in 1918, 1919, people did not yet have models which would explain emergence of this well-shaped peak and the decline which follows fairly quickly. So many scientists started to look at different ways to model these specific peaks. And obviously we have a lot of advances since then, and I will cover some of those so that historical context is fairly clear. But even 100 years from now, we can't really say, as Bill Gates sort of predicted a few years ago, we can't really say that we're ready for the next global epidemic. And he said it in 2018. And obviously, I don't think we can claim that we have been prepared very well for the COVID-19 pandemic in many respects. I'm not talking about modeling preparedness. I'm talking about healthcare system and the whole society preparedness. So that is another slide from the past, from last year. We're looking at Australian flu season. And you see here, for example, these peaks from the previous preceding years, from 2014 to 2018, all aligning fairly well in terms of the timing, right? So, you know, in Australia, the winter is June, July, August, and usually the peak of influenza season happens at the end of winter in August. But when you look at 2019, you see that this peak shaped up fairly well in advance, maybe by 3 months. In fact, even in April and May, it was trending up so high, that an order of magnitude higher than the previous flu seasons, that people started to say that it was a major epidemic of flu, although it turned out to be, as many old school epidemiologists used to tell me, the winter came early. So that was the assessment of the situation in May and in June, that the winter came early. So why am I bringing this to you? Not obviously to show the shape of this epidemic like incidence curve in this particular case. We're looking at the number of notifications, so actual number of cases, not active cases, but the cases which are registered on any particular day. And the reason is that I just want to say that predicting those peaks is actually very difficult. And estimating the intensity of the epidemic, the strength of the epidemic early on, is also fairly difficult. Despite much better surveillance that we enjoy these days, despite obviously much better testing, it's still difficult to predict development, the spread of the disease, mostly because it's not a pure biological phenomenon. It is actually something which has a lot to do with the social system, with the way people connect to each other, with the way people spread within any given country or even any jurisdiction, with the way they interact. So it's a truly complex system, and that's why our group is interested in studying this computational epidemiological problems. So another historical point, and I sort of alluded to that, the scientists who started to really make some headway with mathematical treatment of this epidemic phenomena are Kermack and McKendrick, and then that is a snapshot of their seminal paper in 1927. They were looking at an epidemic of cholera in India, and that's the shape of the plot that they modeled. So the dots are the actual statistics. It's the actual numbers of deaths from plague, not even cholera. And they basically came up with the model which became very famous. It's the essence of the compartmental modeling, SIR or SIS or SEIR. There are many ways to expand on this model, but the basics are that you have a few compartments: susceptible, then infectious, then recovered, which describe progression of the disease in groups of population in such a way that you model numbers of people in each compartment. For example, X is the number of susceptible people, Y is the number of infectious people, and Z is the number of recovered people. And very elegant equations describe these transitions. So the number of new infections is proportional to the product of X and Y. Basically, for every pair of susceptible and infectious person with some proportionality coefficient K, you get a decrease from the susceptible, from healthy people, and the corresponding increase in the infected, which then get recovered with another rate L. So the recovered population increases and the infectious population decreases by that factor. So if you're interested in this compartment Y, for example, which would be proportional to the number of deaths, the growth rate and then the decline rate would obviously depend on the interplay of these two numbers, two rates, K and L. And we'll get back to that in a few slides. It's a very elegant model. It's obviously not fine-grained, it's coarse-grained, but it gives a lot of good predictions. It has good explanatory power and predictive power. And it's basically the textbook model. I will not talk a lot about this, but if you really look up many compartmental models, you will see that they all share that kind of profile where the number of infectious people grow and then decline, while the number of susceptible people, healthy and susceptible, decline almost to zero, and the recovered people grow and then take the full population at the end, assuming there are no deaths in this model. So if you look at the timing of the peak, it usually follows the moment when the number of recovered exceeds the number of susceptible. So basically, with this model, sorry, with this model and models similar to that, the pandemic starts to diminish in intensity pretty much because everybody who could get infected gets infected, or at least the herd immunity, the collective immunity is achieved, and there are simply no more targets for this infection to take on easily, and that's why it starts to diminish. Which is, again, a lesson that we might keep in mind because, for example, in COVID-19, we don't want to get to that level of collective immunity with infections. We might want to get there with immunization when we get the vaccine, but it's not conceivable or should not be conceivable. I must say that we get to these levels with a natural immunity. So different questions, though, that you may want to be answering is not just looking at the aggregate numbers, which are all good to know. You want to, for example, if you want to estimate the burden on your healthcare, all you might want to know is the number of total infections, which you then convert into number of deaths or number of hospital beds, or some other metric which then estimates the health care burden. However, it would still be an aggregate number, while if you want to really plan your resources in a high resolution, you want to know the levels of intensity of this epidemic in different areas. And you may want to know at what time specific areas, local areas or states or territories or jurisdictions in general would peak, because you may want to plan your healthcare resources differently in different places. On top of it, you may want to consider different ways of intervention, whether it is non-pharmaceutical, like social distancing and maybe quarantine, or pharmaceutical, like actual vaccinations or antiviral prophylactic interventions. You may need to know what are the optimal places and times for those interventions. And again, you can't easily plan it with the classical compartmental model, because you may want to get in specific locations and specific times. That's what I will be mostly talking about, because agent-based modeling is a very natural and powerful tool which allows you to answer these questions, zooming in space and time and optimizing across possible interventions. So what is agent-based modeling? I hope you have at least some idea what it is. I will not introduce it in any great detail. But in essence, you are trying to represent actors in your system, agents or individuals, or if you talk about some sort of aggregation, maybe groups of individuals like households, or maybe even at the level of towns, you could still talk about agency, although the most natural approach is to talk, in this particular instance, computational epidemiology. I would argue that the best approach is to represent individuals as agents. And then the question is, how do you define their interactions? Because that's the key element of agent-based modeling. Without defining the way people or agents interact, not much could be modeled. And obviously, this requires quite a lot of fidelity, because otherwise you will be modeling some abstract system which may not be easily convertible into actionable, policy advice. So in case of epidemics, what I will be talking about and what we've been doing, as well as many other groups in the world, we are representing individuals, our agents, using the census data. So the agents come with attributes. We essentially generate stochastically every time we want to run our simulation, or at least a batch of simulations, an artificial population where each agent has different attributes: age, gender, susceptibility and immunity to diseases, which develop over time, and other categories, other attributes that you may think of, occupation, for example. The agent's interaction is something which you define within what we call mixing context or social context: households, household clusters, neighborhoods, communities, workplaces, schools, and different school environments like classrooms and grades. Basically, whatever information you have available in the census, you may want to use in developing the model so that these interactions are faithfully representing a real society. So what are the interactions? We're modeling an epidemic, so all we need to know is the transmission rates or contact rates in each of these mixing contexts, and then the interactions. Essentially, an interaction is driven by the probability of a transmission from the infectious person to a susceptible person, given this social context, and also given the rate of transmission. So the simulation runs over discrete time. Maybe you have daily updates, or twice a day, maybe 12-hour cycle, which we use. So, for example, you may want to update each night the transmission of the disease in households and neighborhoods, and during the day, you update it within workplace and school environments. So that's the demographics and mobility, two layers which are fairly well known. The third layer is modeling of the actual disease. And that needs to be carefully modeled as a progression, natural history of the disease within a single individual. And on top of it, how the interactions happen in terms of the transmission rates and contact rates. How do you start an epidemic? How do you start a pandemic? Again, it's quite an interesting task in itself. Australia is in this situation that usually international air traffic, or as we now know, maritime traffic as well, brings this infection from overseas. And then it is starting to spread from major capital centers, from airports essentially. And you model it with particular probabilities of seeding this infection in neighborhoods of these points of disembarkation. You could vary it, obviously. You could vary the sources of infection, and you could vary the intensity. So the intensity usually is varied by this transmission rates, and you need to calibrate it so that it agrees with this reproductive ratio R0. I will talk a lot about R0, and also attack rates, which essentially mean proportion of the infected people, either nationally or within this context, like an attack rate in children, or attack rate in households, or attack rate in workplace, or attack rate in elderly. Then you want to also model not just the eventual attack rate, but how fast the disease started to grow, which is not just R0, but it depends on the growth rate. And there are many other parameters, including the generation period, which is from exposure in a single individual to exposure in a secondary case. So all of this data usually are eventually, they become available, and epidemiology provides this data. So when you develop a model, there are a lot of free variables but you need to calibrate them so that the model that you are doing actually models a specific disease, either specific virus or a specific bacterial infection or even parasitic infection. I want to spend just a couple of minutes talking about historical background here. I did mention obviously SIR models, SIS, which are 100 years old pretty much. But about 15, 20 years ago, there was quite a significant development coming from Los Alamos National Lab, where people developed this large-scale molecular dynamic simulation of 19 billion particles at the time. And essentially, you are talking about molecular interactions between individual particles. The interactions are defined in terms of some physical phenomena, whether it is charges or some sort of polarities, but the actual global phenomenon is not unlike a diffusion of some physical process. And so people got that idea that rather, or in addition to modeling molecular interaction, you could turn it to epidemiological use, where particles become individuals, people, and the interactions like attraction or repulsion of these particles become similar to transmission and recovery. So that was turned into that computational epidemiology framework called EPICAST, and quite successful application was, I think we published, yes, in 2006, turning it into a tool which allows you to compare what-if scenarios when you play with different mitigation strategies and different approaches to controlling the disease. Because you could obviously hypothesize multiple scenarios. How do you intervene if you have limited resources in targeted antiprophylactics, whether you surround like outbreak areas with circular rings, or maybe you go with like geographic targeting of these places, or maybe you go with the targeting of specific individuals. If you have vaccination, how do you apply this vaccination again? So all of these questions could be modeled with the hypothetical counterfactual analysis, and that's the power of agent-based modeling. So it was quite interesting even now to look at, it is interesting even now to look at this comparison, which was published in 2006. For example, you could see the progression of the disease like baseline model, and with 60% targeted antiprophylactics. And you see with that high level of coverage, if you can reach to the population by after 3 months, the comparison is striking. Rather than having quite a strong cover impact of this influenza, pandemic influenza, you pretty much control it without any real damage. So that's where we started from, right? So I mean, these agent-based models have been developed, like I say, to a very good extent, but tailoring it to either different countries like Australia or different diseases is always a new exercise. And I will share with you the essence of this modeling so that you could at least contemplate doing something similar if you have access to your census data in your country, demographics, if you have access to travel patterns, including long distance, mobility, if you have some collaboration with epidemiologists so that you could model the infection, disease transmission, and natural history in a single individual very well. As I mentioned, we did a model of COVID-19 as well, which is fairly accurate for Australia, but I will talk mostly about the influenza work, which we've done for years, so between 2016 and 2019. We looked at specific virus H1N1, and I will show you a couple of case studies looking at just prediction of pandemic trends. What are the effects of urbanization? How do you do counterfactual analysis? And then how do you measure the efficiency of interventions? I don't have a lot of time, so the slides will be available. I will give a lot of references. I will only try to highlight the maybe pitfalls, what could go wrong, and then give advice what to consider more carefully. Otherwise, you may have a classical simulation situation with garbage in, garbage out. So how do you model these demographics and mobility? I think COVID-19 gave this message quite strongly. It's the same storm, but we're all in different boats. And that's what's modeled with mixing social contexts. So each household is represented here in this scheme by...
Actually, Mikhail, can I interrupt?
Yes,
Because
sure.
this might be a good time to ask a question that popped up in the chat. So John was asking, what are the advantages of calibrating a model to fit some known observables, such as the number of infected individuals, versus using data to determine the parameters such as the rate of being admitted to treatment in the first place?
Well, you see, when we talk about something like H1N1, we are developing a model for a virus which is fairly well known. With COVID-19, when we started doing it in February, March this year, we needed to wait a little bit until at least some parameters became known. At least the ranges of these parameters became known. So it's a trade-off whether you can wait till epidemiology clarifies, or you can't. If you can't, then you need to do your sensitivity analysis and classical uncertainty analysis. I will touch more about that. Hopefully it will get clearer. But at this stage, I'm talking yet about demographics and mobility, which could be done irrespective of the disease. And it's still an important aspect. It took us about 2 years to represent a good model for Australia, even without, it's not rocket science. You just need to do it fairly well, because you have a lot of data that you want to capture, like household distribution, household composition distribution, how many households have 2 people, 4 people, whatever, 5 people, like single parent, all of these age distributions. So you have also household clusters. You could talk about, say, adjacent houses or some sort of neighborhoods where household clusters are grouped together. Then you talk about the wider community. All of it is simple hierarchy. However, people do travel to work, sometimes long distances, and that needs to be represented by a working group or schools, which are also sitting somewhere in between. And that's where the interactions happen as well, because interactions within home environments or community environment, you would have been modeling it in a hierarchical setting. But when a person who lives here travels during the daytime to another place and interacts there with other people who then same night come home, obviously you could see a vector of the transmission quite clearly here. So this information on connecting the residence locations of people and their workplaces is also available in census data, pretty much in every country we looked at. So it's not, again, rocket science. You just need to represent it fairly well. I will not talk a lot about these statistical areas, places of residence, and destination zones. Although I say for the third time, it's not rocket science. There are a lot of interesting peculiarities that you want to pay attention to, because to recreate this connectivity from the census data, you need to be careful that you do not introduce some noise, or you don't amplify some noise which is already present due to anonymization. And we spent another 4 or 5 months making sure that the data we get from the census, when aggregated, agree with the same data, with the same level from the census as well. So there is a paper here which you may want to glance over just to, as a warning sign of what could go wrong here. The first point I want to make in actual modeling of these diseases is, and that's what's coming from this paper, is that you do want to represent this connectivity, as I said, faithfully. Usually in the census you have representations, or you could build representations like that. And the shape of these distributions, like number of commuters over the distance, is an important characteristics. Like for employees, it's more like a long tail, while for students, it's much more geographically aligned with their place of residence. So you need to be quite careful with looking after different slices, different contexts. Another aspect, which is much easier to deal with, international air traffic. And this data is usually available. You look at international overseas passenger flow to all the major airports, and then you see the infection in proportion to all these numbers, which are daily numbers. And that usually provides a good approximation of the pandemic introduction, so infection introduction into the country. I will skip over that. The most important epidemiological characterization, and that probably comes back to the question that was asked, is natural history of the disease. I cannot, overemphasize the importance of it. Imagine a single individual who gets exposed to infection at day 0. At some point, that individual starts to develop symptoms. Maybe it's day 1 or day 2 or 3. And then the infectivity of that person, if that person is symptomatic, grows until some point, say a peak of infectivity, and then it starts to decline. So how do I know that the decline is linear? How do I know that the increase in infectivity once the person is symptomatic is linear as well? How do I know that when the person is not symptomatic, it's 0 infectivity? In influenza it is, in COVID-19 it's actually not. Then what's the proportion of symptomatic people versus asymptomatic? Is it 67 to 33, as some models suggested, or is it 50-50? For asymptomatic people, is their infectivity half of the infectivity of symptomatic people all the time? Or maybe it's a third, or maybe it's flat after some time? So all of these questions, all of these details have to be thought through very carefully. Once you put a model in and you start your interactions, I'll come to that later on, it may so happen that given this natural history of the disease, another parameter, which is called generation time, it's the gap between appearance of symptoms, or rather between exposure in the first index patient and in the secondary case. That gap might not agree with what epidemiologists tell you as well. Like in influenza, we know that it should be around 3.3 or maybe 4. It all depends on R0 as well. And you may have some interesting profile which makes perfect sense in terms of the viral load of infected people, and then the generation period happens to be off the scale. So there is a lot of calibration and validation here as involved, and it's not a simple exercise, and it's not even completely science, because epidemiologists usually disagree, and your model is always at best an approximation of reality. So all you could hope for, that all these triangular profiles that you put in eventually compute the generation period, which is within a range for a range of R0s, so that it's not completely outlandish. that's another example of a natural history of the disease where you also use another feature of agent-based models. Because when you talk about natural history of the disease, a lot of uncertainty comes because people are different. Yeah? People get sick at different times relative to exposure. Some show symptoms after 1 day, some after 2 days, some after 3 days, talking about influenza. But because you deal with agent-based model, you could deal with distributions of these natural histories of the disease across the population. For example, what you see here is that, say, 20% of agents would get symptomatic after 1 day, and then their profile would be like the red curve. Another 30% would get symptomatic after 2 days, and then their profile would be this dashed line. So they get some infectivity after the first day, although they're not technically even symptomatic, but then they get the peak of their infectivity after 2 days. And the last 20% of people would get their symptoms after the second day. So you see, you could vary this history across the agents, and that adds to the power of your modeling.
Well, maybe that's a good time to ask a general question that was asked in the chat. How do you decide what level of granularity to use? So the question was about household size, right? Using a distribution versus an average, but I think the same holds here. How do you decide whether that level of detail is important or not?
Well, you see, I mean, with demographics, we try to use as much data as is provided in the census. So computational power is your limit. So if your computational power is sufficient to run with 25 million or 250 million agents, just do it. In terms of granularity of the model, you have your simulation cycles. For example, here I talked about symptoms appearing after day 1, day 2, and day 3, although I could have added granularity in terms of day and a half, 2 days and a half, because I have it. So again, you could make it more gentle, more smooth, so to say, but what do you gain out of it? So at the end of the day, you validate your model against known attack rates, and if it shows good match, then you're there. Another point is that if your data, for example, on attack rates in different slices of the population, like attack rates in children or older adults or elderly, workplaces, schools, and households is known, then you have to represent this context and verify. Otherwise, you will end up with the classical compartmental model where you have 3 numbers, S, I, R, and all you know is the statistics in terms of these numbers. And sometimes that's all you need. Yeah. So it's a question of what you have as data sources and what questions do you need to answer.
And in terms of computational complexity, a related question that just popped up is whether it's mostly determined by the graph of interactions or the number of agents or both.
Yeah, it's a good question. Basically, I'll show in the next slide, the computational complexity comes really from these 2 equations, and it's pretty much multiplication. So for each agent, you need to check all possible ways it can get infected. For example, let's say that P from J to I is the probability of infection in the context G. So G could be your household or class or workplace or anything else. And for each of these contexts, you see we vary it across G first. For each of these contexts, for the person I of interest, I check all possible J to I infections at any given time N. N is my cycle. So person I could get infected from anybody in a household. And the person could get infected from anybody in, say, household cluster. and from anybody in the neighborhood and from anybody in the community. So this is probability of not being infected from anybody, if G is my household, from anybody in the household. Then I need to multiply it to compute the probability of not being infected in my household cluster and the community, and so on and so forth in my nested Russian dolls. And finally, when I compute this probability of not being infected, I subtract it from 1, and that's the probability of infected. So that's pretty much all your computation. You check for all agents at any given time. So the first loop is always over time, or rather simulation cycle, twice a day. Then for each agent, you check all neighbors, so to say, in every context, housemates and schoolmates and workmates and so on and so forth. So that's pretty much what drives this simulation. And for example, to simulate a day with 25 million agents, population of Australia, we need 20 seconds. So when we have 180 days, 28 weeks, that runs over 2, 3, 4 hours, dependent on how many infected agents there are. It's actually quite ironic that the high intensity of the epidemic, the longer it takes to compute each cycle. So when we see that it takes longer to move from a cycle to cycle, we know that we're closing to a peak of the epidemic. Another good question might be, where do I take this probability of infection from? I started from this second equation. These probabilities of infection from J to I, in every context G I can think of, must come from somewhere. And they come from the rates which are my inputs. So these rates Q are listed here in the table. And without these magic numbers, I would not be able to run any simulation. The function f is nothing but what you saw here. That's my function f, whatever profile I add in. And kappa is the global scalar that plays some calibration role. I'll talk about that later on. But the real input is my Q. How do I know that in the household size 2, the transmission rate from anybody to a child is 0.009, but from anyone to adult is 0.039. So all of this comes from different epidemiological studies. For example, we take it from a work by Koshemes and his colleagues, and other studies as well. I mean, there are quite a body of literature where people actually have done empirical studies for all these household sizes. What's the probability of transmission from adult to adult, from child to adult, and so on and so forth. Without these numbers, you will be guessing in the dark. However, this is somewhat invariant now that we know this. It's somewhat invariant across a range of respiratory diseases, so influenza-like illnesses, so to say. And even with COVID-19, these numbers happen to be representative. Another point about this kappa is that these numbers don't have to be completely absolute. They're mostly important because they shape the relative weights, so to say. And even if these weights are not precisely like that, there is this global scalar which scales them up and down, playing the role of this R0. So if you don't know these numbers, you could start from the very same table. What's important, for instance, that the probability in the household size 6 would be, I don't know, 5 times less or 4 times less than the probability of transmission to a child in the household of size 2, which is rational. So it's not as difficult as it may appear. Then there is the role of social networks, and that is quite clear that sometimes if you don't know these transmission rates, you deal with contact rates. I will skip that slide because it's more detailed than I have time for. But what I'm getting at is that sometimes you don't have transmission rates, but you at least know the contact rates. What are the rates of contact between people, contact probabilities, which again, you convert, you translate to be compatible with this equation. All you need to do is that you deal with the probability of transmission at any given tick from infectious to susceptible in different contexts. Okay, now I need to talk about the R0, and sometimes it's called reproductive ratio, and sometimes it's called reproductive number. So hopefully you know a lot about it, but there are quite a few misconceptions. And in terms of agent-based modeling, it's not that straightforward to compute. It's still easy, but it's not straightforward, and there are ways to get kind of imprecise. So essentially, it's a number of secondary infections. If you have your patient 0, how many on average people in otherwise susceptible population will get infected? Say in Ebola, R0 is equal to 2, in SARS, assume it's 4. I'm not saying it is, it's just a scheme that I took somewhere from the web. And even in this nice movie Contagion, there is an epidemiologist who explains it to people, and sometimes they go gloriously wrong. Like I remember we were going from 2 to 4 and then to 16 in one go. So it's not squaring the number, it's really just multiplying by a factor. It is still misleading, this picture, a little bit, because it's important to know that the concept applies by, say, doubling, if it's R0 2, in otherwise susceptible population. If one of these 4 individuals would have been already immune, then we would not have gotten 4. But in the beginning, usually the targets are all available, so to say, and so you could double if R0 is 2 for a few iterations. So why is it called a ratio? So far, I define it loosely as a number. It's a reproductive number. So why is it called a ratio? It's called a ratio because in the context of a particular model, which we already talked about, this compartmental model, where you have number of susceptible people, a number of infectious people, or infected people, you have 2 important constants. It's a rate of infection, beta, to get infected for each pair of I and S, minus the rate of recovery, beta and gamma. And beta divided by gamma happens to be exactly that reproductive number. So in the context of this model, it is a reproductive ratio. So the number 2, that you get 2 secondary cases for each index, means that the rate of infectivity is twice as high as the rate of recovery. Obviously, that's what it is in the context of this model. So if you have a different model, you need to still go back to actual definition that it is a reproductive number and not a ratio. And in some models, you may not even have these rates. Even more important, that this number is not a feature as such. It's not a feature of a virus or bacteria. It's a feature of how this virus spreads in a given society, in a given social context. So it's not a pure biological phenomenon. It has a mixture of social phenomena and real microbiology of this virus. So when you deal with agent-based models, you have to be very careful that you don't misrepresent this number. So first of all, I need to relate it to, that's an ugly equation, but I need to relate it to that global scalar kappa. And all I'm doing here, you may ignore the first 2 lines. I define R0 essentially as the number of people who get symptomatic, given that some agent is, my index case, J is first infected, symptomatic. So all I'm computing here is how many. That's why it's a double sum. So how many agents get infected given my model. And that formula is actually proportional to that kappa, that global scalar, which gives me a good handle on comparing R0 and kappa. Remember, if I go back, this kappa was this global scalar which converted these transmission probabilities into my probabilities. So when I say that R0 is proportional to kappa, essentially the lesson is that the way I convert these weights into my R0 is this kappa. So what I showed you that this formula is essential in linearization. What I showed you here is that R0 and kappa are almost one and the same. However, how do you actually estimate this R0 from your agent-based model? Because you put in this rate, this column of numbers, and then you run it, and you might say, okay, let's see my infection here and see how many agents got infected eventually. And you could do it quite pragmatically in a very simple way. Once the secondary agent gets infected, no more infections happen. So you know that every secondary infection happened from the first one. So you could do it, I don't know, 10,000 times and 100,000 times, and you could get some average of the secondary infections, and you'll say, okay, that's my R0. And that would be wrong. Not very wrong, but it would be wrong because the definition of R0 actually says that this index case has to be a typical index case or a random. But how random is it when I actually drop my initial infections in my artificial population and then count secondary infections? It is actually quite a tricky question because typical doesn't mean random. Why? It happens to be not the same because look at this plot B. The attack rates depend on age groups. So you see that given a particular disease, and when you vary this global infection scalar kappa, the number of affected people in different age groups differ. For example, like 0 to 4 children have a lower attack rate for any given kappa, for any given R0, so to say. You could have a vertical slice and you'll see that the proportion across age groups is obviously not uniform, not constant, which means if you, when you randomize your initial infections to compute R0, you hit different age groups with different probability, which is not the same as the actual attack rate. You introduced a bias. So what you need to do is essentially to reweight in computing your R0 from these samples. You need to reweight these samples with the distribution which is proportional to what I'm showing you here in plot B. And then the dependency between the R0 gets basically higher. The original line which connects kappa and R0 is this red line here, and the real R0, not real, it's age stratified, is somewhat higher. And it is much closer to the real R0 because what we also know about R0, and let me show you this, is the following. Why is it so important? I mean, I didn't say it because I hope you all know that epidemics start when R0 is higher than 1. If R0 is less than 1, epidemics do not sustain themselves. So if you look at this age stratified computation of R0, you see that it's a classical emergence of the epidemic. Once R0 is higher than 1, you get this profile. While if you do the random and not typical index case, this criticality happens at 0.7, which obviously is not true. You could deal with it as well. I mean, all you need to know, all you need to validate is the attack rate as such, but it's somewhat uncomfortable that when you see a criticality profile picking up from 0.7.
So Mikhail, can I interrupt you here? So we have about 30 minutes left. This is great. I've been keeping a list of all the questions. There's quite a lot of them in the chat. We have about 4 or 5 questions that relate specifically to R0 and social structure, what you just talked about. Do you want to keep all questions for the end, or would you want to answer some now?
I would answer maybe 2, 3 questions now, and then I'll fast forward to the network side.
So, I mean, I can summarize some of the questions together. So Oskar and Taylor and Harold, to some extent, were wondering how these models can deal with some of the chaotic elements of disease spreading or rare events like super spreading events, and how R0 being just an average might be able to deal with this heterogeneity.
Basically, every time we run it, and actually this slide is a good answer to some extent, we run it over multiple number of times, and we also generate population a few times. So there is an actual spread. Stochastic element is present here, and the standard deviation that you could see shows that it deals with these super spreading events fairly well. I mean, even with COVID-19 that we've done, these ranges are quite manageable. It's not averaging in the same way like in compartmental models, but it's because, you know, some runs are quite unusual. I mean, they could, you know, show you quite an interesting deviations, but they do average to some sort of commonalities. And as R0 is growing from, say, 1 to 2, you see that the curves get close, they get high in terms of the peak, and the peak happens earlier with high R0s. Yep, maybe next question.
And Mariah and Jan were both wondering about sensitivity analysis. So especially when there is heterogeneity like super spreader, how robust are the predictions? And also how do we know to determine whether all details that we're putting in matters?
Yeah, basically, we haven't published sensitivity analysis on these models, but we are going to do it for COVID-19. All you do is basically, you use whatever sampling method you like, say Morris method, and you check what is the response, for example, in R0, when you change, for example, some of these parameters I mentioned, either kappa or maybe talking about this natural history of the disease. Anything here you could vary, right? I mean, time to peak, the infectivity of asymptomatic people, the length of the recovery period, is it 5 days or 6 days? So all of these things you vary, and you measure the responses, and then you see whether your model is robust or not. So it's a classical method of doing sensitivity analysis. There's nothing unusual about ABM in this respect, apart from ABM adds in the stochastic distribution within the population, so it's robust in this sense as well. So let me move on, because I have quite a few slides. I will mention herd immunity threshold as a dependence on R0. Many people know about that. So given R0, you could also compute the herd immunity threshold. Say R0 is 2, then it becomes 50% minimum level, minimum proportion of the population that needs to be either immunized or infected to get the herd immunity. So again, spatial components you could easily visualize. Here you have 1.5 and R0 2.0, and you see that they're quite different, these trajectories, because you see a spatiotemporal representation and not just a single number. So these pictures gave us the idea to look at spatiotemporal synchrony, how synchronous are the peaks in each of those areas. And that is a question that many other people have been asking. Is the major characteristic of the disease wave-like diffusion, so it just grows like that? Or is it more hierarchical, that it jumps from one major city to another and then spreads within them? And you could answer these questions that it's more hierarchical by contrasting how does the synchrony, which is essentially inverse of variance across the points in terms of their peak times, how does it depend on the size of your census area? So the larger your area, say from villages to cities, the more synchronous they become. Therefore, the spread is more characterized by the hierarchical social structure rather than uniform diffusion. Another interesting work that you could do with ABMs is the following. Look at this picture, for example, just in terms of the population growth. In Australia, urbanization is quite a rapid phenomenon, and you see over the years, the proportion of people, the growth of the population in the cities was steady, but non-city regions or remote regions are actually declining, negative growth. So urbanization is a major factor. The incoming international air traffic is also intensifying. So you have these two major factors. Which one will be affecting the hypothetical epidemics more? That was the question we answered here. We looked at the same virus, H1N1, but looked at three different historical periods, each represented by census data. And you see that the same dynamics, the same natural history of the disease, the same transmission probabilities, just different air traffic and different population structure mean that the peaks intensify, they get higher, and they happen earlier. And then on top of it, you have different waves, like urban wave and the rural wave, which get separated, and that's what will be visible in a second. Let me explain these two waves. Here, it's a timeline, but what you see on the vertical axis is the number of areas which peak on that given day. So for example, in this greenish area, it's those major cities like Sydney and Brisbane and Melbourne, which are peaking, while in this pinkish area, it's like regional Australia. And you see that in 2006, these two waves were very well shaped, with number of areas peaking in the second wave was higher. 2011 was like this, and 2016 was like that. So that was a third trend, in addition to the peak happening early and higher, that the waves were getting more separated, and the second wave getting more diminished. I'll skip that slide, it's counterfactual analysis. And I will probably skip this investigation of pharmaceutical interventions because it is quite demanding in terms of time to explain how do you then distribute the resources, what's the effect of particular antiprophylactics on incidence and so on. So I'll skip these two slides as well. And we'll get to this summary of ABM, which I planned as 2/3 of the tutorial, and 1/3 I still need for our case study on network models. So sensitivity analysis is to a large extent embedded in heterogeneous agents, but you could do classical sensitivity analysis, and it's also quite useful. The focus is individual based rather than aggregate. You could deal with age-dependent epidemic characteristics, which sometimes is a challenge for compartmental models and even network models. You could achieve high geographic accuracy. You could investigate cross-jurisdictional impact, like that first wave and second wave, they're associated with urban and rural regional wave. You could study interventions in terms of their time distribution and context dependence. You could do different counterfactual analysis. You could say, what if, I skipped that, but what if international air traffic, right, which we observe now, was applied to 2006? Would that change anything? And critical phenomena analysis. Two major weaknesses, which we talked a little bit about. We need to calibrate multiple parameters, and we need to rely on high performance computing. But I think the second one is a non-issue right now. And calibration, although it is a challenge, you may, if you're careful enough, you may actually do it well. So before I go to my next part, are there questions about any of that, any of ABM?
Sorry, I had a hard time unmuting myself. So the few questions that are left, Jan Carlo had a very general question, which was, is there a similar model for ideas infection or memes in the society? Like how general are the tools that you're presenting right now?
No, I mean, look, it's a very deep question, and obviously information diffusion and ideas could be analyzed in this context. It's just that when you deal with the virus, you could still compute these transmission probabilities from empirical studies, while when you talk about memes, it will be much less precise. Even when we talk about other diseases like chronic diseases like obesity, it's well known that there is a peer pressure on modeling obesity, and people do change their behavior depending on what they observe in peers or within families, but even that is hard to quantify. So I think with memes, we're still a fair way away from it, but it's not impossible.
And I had a question related to how your experience in communicating some of these results has been when you talk to other scientists who might not be familiar with ABMs or policymakers. How do you report the output of your simulation? Just averages, confidence intervals, like what do you show?
Well, I mean, so far the most successful, more impactful traction was coming from advising on actual interventions, not in terms of, let's say, confidence intervals and ranges of applicability. That all comes as some small print somewhere at the end. But when you say that, for example, in managing COVID-19, you need to have social distancing of at least 80%, and even 70% is not enough, people listen, because that's something which is actionable. And that's what's sometimes difficult to achieve with compartmental models. For example, advice in Australia was from a government model that R0 should be reduced by 33%. How do you do that, right? It was not answered. While if we say, well, you need to achieve 80% social distancing, it means that 1 out of 5 should sit at home. So that, I think, is the most direct way to imbue people with this understanding. Interventions.
Thank you. So we have about 15 minutes left. I'll let you go on. I think you have a window that just popped up. Okay.
Yep. So, yeah, this is a quite different study, and I will probably do it in 15 minutes. So here we model Salmonella epidemics using networks. So when I talk about network-based modeling, there is a lot of network-based models in the classical sense, where either individuals represented as nodes and vectors of transmission are the edges, or whole townships are represented as nodes and the travel between towns is represented as edges. Here we will talk about networks of the population of different strains of Salmonella, and what's the connectivity in this population of the bugs can tell us about predicting the epidemics. So it's quite a significant issue for Australia. We have this dubious honor of leading the world in terms of per capita diseases, per capita cases. So it's quite a fatal disease in Australia. And STM is a particular strain, non-typhoidal salmonellosis. The drivers of the evolution of this STM remain poorly understood. The database that we've got has about, 1,600 unique representatives of this population, and they all mutate from one to another. How do they do it was the question we wanted to answer, and I think a few lessons would be interesting in general, not only in terms of this foodborne disease, but in general to computational epidemiology and even network science to some extent. So that's a classical timeline that disease surveillance reports show that every summer it picks up. Why does it do so? The prevalent understanding is that, well, it so happens that in summer, obviously, there is more opportunities for this bacteria to proliferate, and there is no real evolutionary drive, so to say. It just so happens that these mutants co-circulate, and some of them picks up, and you get an outbreak. So the data set covered about 10 years, and we used a particular genotypical analysis, genomic analysis, where you represent each strain, each mutant with 5 or 6 numbers. I will not get into microbiology of it, and I will skip this video. But what is this MLVA? This is like a genomic sequence, a genetic sequence rather, and you look at how many times a particular sequence of letters, say gata in your Gattaca, gets repeated. If you have 8 repeats, then you say in this particular fragment, in this particular locus, this number is 8. If it gets repeated 9, it's 9. If it's 10, it's 10. So that's all there is. It's not as detailed as the whole genomic sequencing data, but it just counts representative numbers. And the distinguishing power of these numbers is very high. So when you deal with a particular strain of Salmonella, that's what you get. 3 repeats in this fragment, 9 repeats in here, 8 repeats here. The last one is just a repetition. You could split it as well, by the way. You could split it into something like that, as people have done. Doesn't matter. All that matters is that each mutant is a sequence of numbers. 6 numbers or 5 numbers. And then you get, as I mentioned, 1,675 unique sets of these numbers with the date stamp and age of people who got infected and so on. But what's important is the numbers that you see here and the date stamp that you could sequentially process. Here it shows that across the years, some of these strains have been quite popular, so to say, that 259 infections caused by that particular strain. And a neighboring strain, like look, 39713, and this is 39813, they differ just in one tandem repeat. Which one mutated to which one, we don't know, but that one got another 100. And next year, you got some of those, and some of them relatives, where the 3rd or 4th locus, 4th fragment got changed. And you could almost see this history of evolutionary history going on. So it's quite interesting. But the health authorities just look at that in this kind of straightforward way. They do know what's similar to what. It's not, again, rocket science. But what exactly is this dependency, and what can you extract from it, was the question we wanted to answer. So what we've done, we build a network. So let's talk about that, because that's important. So how do we build a network? How do we say that 2 mutants must be connected. So you compute the distance, and we use a particular Manhattan distance, L1 norm. So if that's your one mutant X, and that's your mutant Y, and they differ here a little bit, and they differ maybe here a little bit, you say, well, that's my distance. You take absolute values, and my distance becomes 2. And 2 is close enough, right? I'm just joking. You could have different ways of clustering. You could have like completely partitioned clusters where each cluster is mutually exclusive from another cluster where you group these mutants, or you could have overlapping clusters. Again, I don't have time to talk about that, but it's not that difficult to provide a characterization in terms of this distance. Once you get the distance, you could do a lot of things. An interesting thing that we found is quite predictive about the epidemics is the closeness centrality, which is purely a network measure. So for each node in the network, and each of these mutants is a node in my network, you compute how connected it is, what's the average distance to all other nodes, and that is my denominator. So the inverse of that average path length is the closeness centrality. So if that mutant X has a lot of relatives, it will be connected to a lot of them. So the average distance to all other nodes would be small, and therefore closeness centrality will be high. So that's how the network looks like. You could also make it directed, but I will not talk about that, because directed needs temporal timestamps on when they appear. You could know which one sort of mutated to another one, and it looks like that. But the results that I will be showing you are not dependent on the directions. So the first result was this, just looking at the average path length in each of the networks, because at every time point you could build a different network because you have different nodes and different mutants and so on. So you could have, say, a network lagging, like moving average, like 365 days in the past. You build a network from all these connections, and you compute its average path length. And every day as you move on, you compute this average path length again and again and again. And here are two plots. One is the actual prevalence of this foodborne disease in Australia over 9 years. And then you have the green curve showing the average path length. And you see that the correlation with prevalence is quite striking. 0.7 at 100 days look ahead. It means that the more connected the network of these mutants, of these strains is at any given time, the more likely that you will have an epidemic outbreak 100 days later, like 3.5 months later. So that's the average path length. Then another very well-known characteristic is the clustering coefficient. It's how well my neighbors, if I'm a node, are connected among themselves. In the classical network sense, you essentially count number of triangles in a network. So it's a different representation. It's not the closeness centrality. It's more localized. It's more clustering around each node. And again, the black curve is exactly the same. It's my prevalence over 9 years. The clustering coefficient has predictive power. It's correlating with prevalence. And again at 70%, 50 days ahead. Not 100, but 50 days is good enough. I can predict with 70% certainty that an epidemic might happen just looking at what I currently know about the currently manifested strains. Okay, anyone who knows network science will guess what I will be talking about in the next slide or two. If I have my average path length, diameter of the network, and if I have my clustering coefficient, what am I going to look at? Small world networks. So we all know that small world networks is a very interesting topology. just by randomly rewiring a few nodes in a regular network, you could create a small world. If you continue rewiring, you will get to random network, but let's say 10% gamma 0.1 rewiring probability, you will get a small world topology. So what's interesting about it is this. Again, from Watson-Strogat's famous paper. So the average path length profiles like this, and that's where the small world is, while clustering coefficient profiles like this. So what's special about small world? It means that the diameter is already small. You could get anywhere in a network very quickly, but there is still local structure preserved. It's quite, it's quite clustered. And that's where the small world is. So the ratio between C and L, or normalized ratio between C and L, is small world coefficient. And that's what this sigma C over L is for the same profile of the prevalence. If you compute small world topology or small world coefficient of these networks, strain to strain, mutant to mutant networks, it will give you predictive power 300 days ahead, a year ahead pretty much. Not at 70%, but at 60%, which means if I have my network of strains, salmonella strains as it is at any given time, I could predict if they're small world, it means an epidemic is coming. If it drops, then no epidemic next year until it goes high, and then I will get an epidemic next year. Again, it's not perfect. 60% is nowhere near perfect, but it gives me an interesting handle to say that this evolution has its own structure. It's not just randomly co-circulating strains. They have their own logic. So what's the logic? And that's my next and last slide pretty much. The logic is, I'll skip that overlapping versus partitioning, just think of clustering. It's an interesting slide which sort of shows that a family of those strains could be completely replaced by another family pretty much suddenly, and we will be arguing that there is a logic in this kind of transition, that all of these blue strains are clustered somewhere here on the periphery of the network, while the green ones are closer to the center. Their closeness centrality is higher. But it's not as simple that from periphery, you always go to high centrality. We thought originally that's what's happening, and the moment the strains get to a central place in the network, they're dominant. No, there is another path from the center somewhere else. And that's my last slide here. It's a bit busy, but let me explain what you see here. On the vertical, you simply have average cluster prevalence in a family. On the horizontal, you see closeness centrality for individual nodes. The color is in reference to a single most prevalent, most dominant cluster, which is our reference point here. And you see that the gradient has an interesting structure. There is one genetic branch here as it goes kind of away from it, usually back in time, because the evolution goes along this path to higher dominance. But the other branch goes away along this genetic branch, this gradient. So what does it mean? It means that when this evolution explores the space, the mutants are trying to acquire a more central place. Their closeness centrality grows from 0.03 to 0.08. However, once they get to this highest centrality possible in this population, they start losing their genetic relatives while still increasing in their dominance. So that is exploration, and this is exploitation of the search space. So they're losing their relatives because they're getting more dominant place in the niche. So this network-based analysis gives you now not a global characterization in terms of global centrality, but a local characterization in terms of nodes' local centrality. And that's pretty much the end of this part. Here, I'm just summarizing what we've done. We quantified diversity, variability, and you could do it too if you have the data. Once you do it, if you have the network, it makes sense to investigate its global topological properties, what it means in terms of global epidemic properties, and then local topological properties. What does it mean in terms of individual jumps, individual evolution? And then I have a shameless plug about this new special issue, entropy, and finally references. Yeah. All right. So how are we doing on time?
We did great. We're 3 minutes over, but I think we can take, we started late as well, so I think we can take maybe 2 minutes to finalize the Q&A. We did manage to ask most of the questions as we went. Just a reminder for folks, the next tutorial, which is Cartesian genetic programming, will start in a minute or so in the other lecture hall, so lecture hall B. In the meantime, feel free to unmute yourself if you have a quick question for Mikhail. I will ask one question that did pop up in the chat. Abderrahman was asking, how do you adapt models to other factors that change on the fly, like policy changes, governmental interventions?
Yeah, it's a very topical question. With COVID-19, we calibrated our model at the end of March. We put preprint out and had a lot of media coverage, and we had access to government as well. So people started to change their behavior, and the government started to change the policy. So social distancing has been quite successful in Australia for at least 3 months. And now the question is, okay, you have a model, but the reality sort of changed, right? So how do you amalgamate your model and the reality, which partially is the result of your model and partially it puts the downward causation on your model? There is just absolutely no simple rule of thumb kind of answer to this. You are just trying to, well, what we're trying to do, you could also be doing similar things. All you could do is to try to calibrate the reality as much as you can. So if, for example, the reproductive number are effective, not are not, is better estimated right now, then you could start from here. If you know that there are some areas which are in local lockdown, say in Melbourne right now, you could again start your model from this state. So in agent-based model, it is much easier because it's already diverse in terms of space and time. You could inject your intervention at any given time. You could localize your lockdown in any given place. But you still need to be, quite gentle with this, right? Because if you talk about interstate border closures, you need to be, developing it fairly carefully. So there's still a lot of work, but at least there is a path.
Right.
So if I did compartmental-based modeling, I wouldn't know where to start right now, right?
That's right. So I think this is a great place to end it. So thank you very much. This was great, especially the last few topics you covered. I think were really, really interesting.
Thank you, Ron. Yep.
So with that said, I'll invite everyone to switch around to lecture hall B if you want to follow the next tutorials, or to take a break if you need it. There's no rush. All right. Thank you very much, all.
Sure.